What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Godin, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone. Welcome to another episode of the Gestalt Education Show. We're winding down our Toronto trip, so we were lucky enough to spend a couple days with Stu, and now we're with the next big thing. So Mark Scappaticci, Scap. I'm going to mispronounce it, but we're just going to call you Scap from here on out. So Mark, your CV is insane. So I was doing a little bit of research on you and stuff. I mean, you have basically seen everything, you've taught everything, and you've treated everything and everyone. So you've kind of gotten a reputation for treating the elite of the elite, the best athletes in the world that come through Toronto or across the country. You've also got your name because you teach the best of the best these things, whether it be acupuncture, dry needling. You're an elite A.R.T provider. You've taught A.R.T. You've kind of cut your teeth in A.R.T. And so today's big podcast, we're going to try to really expose integration, which is the non-hidden secret behind this podcast. Is how the hell do we go to a weekend seminar, we learn all this cool stuff, Brett, and then we got to apply it on Monday and actually use it with our patients. So, and not treat them for 3 hours, right? Yeah. Actually be able to treat them somewhat effectively. So could you maybe just give us like a quick background on, maybe your early influences? Before we got on air, you talked about the first time you learned acupuncture was in Sri Lanka. So you've been all over the damn world trying to learn this stuff. So maybe just give us a quick little intro on, how you started to acquire some of these skills, and then we'll kind of get into some integration later.
Yeah, love it. Sure. So when I graduated way back when, we had a few months before we could actually practice, and I was really interested in acupuncture. And so, locally, most of the courses were like lectures, and you really didn't get to apply the needling, and I was really interested in applying it. So there was a place in Sri Lanka at the University of Alternative Medicine where you can go and actually treat people. And as a graduated chiropractor, I could actually apply my chiropractic practice at the same time. And so, the first day we're there, the guy gives us 3 points and says, okay, start putting those 3 points. It was like, wait, I didn't even go to a lecture and I'm already sticking needles in people, right? And, in this place, it was a free clinic. So people from all over, would come there. People would be walking hours to this free clinic, and, it's like an open area. It was kind of really, third world-ish, but it was a phenomenal experience. And I saw things that, you're never going to see in this country, hopefully. And, I started to needle and do, my chiropractic treatments, and I really saw that, things that were, taking, a normal amount of time in my chiropractic treatment, when I added acupuncture, there was like, this kind of magic that happened where, people were getting better faster. And then I really saw the power in adding acupuncture as a modality to help improve my outcomes. And so when I came back, I started integrating my acupuncture, and I took the sports fellowship course at CMCC and got exposed to a bunch of different things. And A.R.T was just kind of coming up, and it was just coming out. And so I registered for those courses, and I think Leahy was one of my big influences way back then. And that addition to that soft tissue component at that level, at that detailed level, really impacted, my ability to really improve my outcomes. And so the combination of doing some needling techniques with some manual techniques and manipulation techniques, really helped improve my outcomes. And, one of my passions was to, work with athletes and help them perform better, not just treat sports injuries. And treat, injuries in general, but I really was interested in saying, okay, how can we impact athletes and improve their performance with our hands? And, I was volunteering with some local local athletes, and I was at this track meet in Hamilton, and this guy comes up to me and says, "Hey, are you Scap?" And I said, "Yeah." And he said, we just finished the semis. Can you tune up? Are my guys? Someone was telling me that that they should come and see you, right? So it was Donovan Bailey, and so I treat him, and the guy comes back and says, "What the hell did you do to Donovan?" So I got worried. I thought, did I do something wrong? And he said,
I don't know what you did yesterday.
He said he ran a PB. Like, he won the race and he ran a PB. And I said, okay, that's great. I mean, validating some of the things that I'm doing. And then he said, hey, can you come next week to Calgary? And I said, no, I can't. I got, whatever I'm doing. And I didn't know who anybody was. And then 2 weeks later, he said, can you come to Montreal? So I said, sure. So I think he came second in Calgary. And then in Montreal, in Bruni Soren's backyard, Donovan PB'd again, and he beat Bruni in his backyard. And so then, this was his agent that I was dealing with, and he said, like, this can't be coincidence. Like, what are you doing? And I said, I kind of explained my model about, looking for barriers in performance, which is like restrictions in range of motion, and, applying needling and manual techniques to kind of help improve that, and, integrating different modalities at one session. It really kind of had a big impact on function, and that ultimately showed an increase in performance. And so, long story short, then Donovan ended up breaking the indoor world record. In '96, he broke the world record and had gold medal. And his agent brought me down to a weekend when they had 20 athletes competing, and he said, okay, can you treat all of them? Because is this just something that you do with sprinters, or so we had distance runners, we had high jumpers and long jumpers, and 18 out of 20 of them either had a season's best or personal best time. And so his agent saying, hey, listen, this is kind of interesting, whatever you're doing, so we want you to work with our group. We had a large group of athletes, and so that year I was probably gone 40 weekends. I was flying to Europe on Thursday, coming home Sunday, going back and forth to all the, at that time it was like Golden League circuit. So, going down to Austin, and, I was very, very fortunate, and I always thank God, and I feel very blessed that I had these opportunities to meet some of these amazing athletes and their coaches. Dan Paff was coaching Donovan at the time, and so I got to work with Dan while he's training Donovan, and we watch Donovan run, and I do a little treatment, and just to help improve his performance, and so that really set the stage, for this integrated approach and how effective it is at optimizing performance. But then you can take the same concepts and apply them to injured people. So there was a girl who, when I was in Austin working with Donovan, where he was training, there was a hurdler that had a knee injury, and she, couldn't train because her knee was bothering her, and someone said, you should go and see the Scap. And so I take a look at her, I treated her, fixed her knee problem, and she came to me 2 days later. She goes, well, I don't know what you did, but man, I'm not feeling any pain anymore. And she said, do you think you can help somebody's hamstring? And I said, I don't know, that depends, right? So I get a call from Bob Kersey, and Jackie Joyner Kersey. It was her last year it was going to be her last Olympics in '96, right? And so they fly me down to St. Louis, and I'm getting the read the right act kind of thing. Not really the right act, but her personal physician was an orthopedic surgeon, so he's asking me, grilling me on what am I doing, why I'm doing this, because she couldn't run she could hardly run 100 meters, right? Like, she could run, but like limping. So I treated her one time. She could, after the first time I treated her, she ran 100 meters. It was like no pain, and relatively after this, I treated her the next day again, and she was fine. And she ended up competing in the Olympics at '96, and she mentioned she was being interviewed and mentioned my name. She called me Dr. Scappaticci. And so, but that was like it was a great experience to see how you can apply the same principles and integrate treatments, and and really make some improvements. And so the orthopedic surgeon was also the local team doctor in St. Louis, and so he said, hey, we have a player that's injured, and can you have a look at him? And I said, yeah, sure. And he's supposed to be out for a couple of weeks with an injury, and I treated him, and he played the next game. And so I ended up working with that team because of helping out a little bit. And so that was just integrating the treatments, I think, is a really important thing. Like the more tools you have in your toolbox, I think the better house you're going to build, right?
Absolutely.
So.
And knowing when to use what tool at the right time is like a critical part, I think.
Yeah, and I mean, listen, I've been doing this for almost 30 years now, and I still don't get it right every time, with all the experience I have. And that's why, I call it practice, like you be patient. I'm just practicing while I figure out what, I'm practicing here. Let me figure out what's going on. And so as long as, you're very, attuned to, is what I'm doing having an impact or not, right? And so if you're not seeing the progress that you think you should, then try something different or add something different. Or,
what are some of the audits you like, Mark? Like, what are some of the ways to know, besides pain, that you're having the desired effect?
Function. So, if we just look at MSK and, MSK injuries, the majority of pain that people experience is a result of soft tissue dysfunction, right? So anytime there's abnormal tension in the system, over time it could be something like, for example, a runner comes in and says, my knee's starting to bug me, and now it used to bug me at the end of a run. Now when I get into 5K, my knee starts hurting me, right? And so you have to look at that person and figure out, okay, the diagnosis is going to be patellar tendonitis. Why? Because, he points to his knee and says, this is where I have pain. And so you just give him the Latin name for whatever he's pointing to and add itis on it. And so, it's not really a diagnosis, right? It's the same thing for a shoulder problem. Someone points to their biceps tendon, you have bicep tendonitis. That's not really a diagnosis. And so you need to understand, how the forces are being transmitted through the body in a way that, that tissue is getting more force being transmitted through it over this run, or that tissue can't handle the load for whatever reason.
And do you think that's more observation, palpation, a little bit of both?
So that's a good question, because, there's all these functional screening tests and all these different things, and in my opinion, when you're learning, I think it's extremely important to do that. I think it's really important that you look at how people are moving so that you see them move, and then you do your manual assessment and you can start to see patterns, and so that's what I used to do when I started, but now I don't have to. The important thing about functional testing, though, is that if you take, here, an example. I did some work with an NHL team, and I did all these assessments on the team, to look at imbalances and functional problems. And the GM says, okay, so what did you find? And so I said, well, the guy who scored the best was their goalie, who was second string goalie, who had back surgery and was doing all kinds of core stabilization exercises, and very diligent and super disciplined. And the guy who scored the worst was a rookie they just signed that was he's a superstar now. And when I told him that, he goes, are you kidding me? He goes, this is we just signed it. He's going to be our biggest contract. And I said, listen, these tests don't tell me how a guy plays hockey. It doesn't tell me how good of an athlete is. You can give me the five best soccer players in the world, or top 5. I can't tell you who the better one is until I watch him play soccer, right? So these functional tests, a lot of people put so much emphasis on a score of a test that, this is, they can't do these tests. And it doesn't tell you anything other than they can't do those tests, right? So, I can do one thing to somebody, one little treatment, and have a complete global effect. So, there's different screening, systems out there. And so say, 21 is the high, and, if you get this, if you have a 13, you're kind of not so good. And, an example was this guy had a score of a 13 out of a 21 in this functional test, and it was okay, you have to do all these things to improve your score now. And I said, well, you don't have to do that, because what's the underlying dysfunction that's causing him to score 13? And so I did a single needle treatment, and his score went to 19. Just one treatment, 1 second, boom, done, right? And so that just shows you that, these functional tests are a piece of the puzzle, right? So you look at the functional movement patterns, you take your patient, you do an assessment on the soft tissue, and you're checking for mobility. And the important thing about mobility isn't, okay, say, just to make it simple, if I do a straight leg raise test, and the person left side and right side go to 90 degrees. If the left side starts to increase tension at 45 degrees and I have to use more force to get it to 90 degrees, is there an equal force between the left and right? They both go to 90, but I'm having to push a lot harder to get one side to 90. And so that's telling me there's something wrong in the soft tissue system that is going to lead to dysfunction, and it in a global way. You could have a hamstring injury that's going to cause your shoulder to be a problem. So if you're a pitcher, say for example, if you have ankle mobility issues, you might end up having shoulder symptoms because the way your body changes its motor coordination as a result. And so it's a combination of, most important thing, taking your history, okay? And when you take your history, where does it hurt? Most patients come with a diagnosis. And so, someone will tell you have lateral epicondylitis, and you say, okay, well, where does it hurt? And they're pointing to their attachment of their extensor carpi radialis longus, which is the lateral epicondyle. And so, knowing exactly what the anatomical structure is, it's the pain generator, is critical. And then you have to assess the tissue to figure out, okay, why did that tissue fail to handle that stress, right? And it's obviously it's always easier if a guy gets a long drive to the quad, or he gets a puck in the shin. Those are easier to fix than I'm an athlete who's running, and every time I get to 10K, the slow buildup of symptoms, right? The slow buildup of abnormal tension. Your nervous system will continue to adapt. Your body will automatically adjust its firing pattern to adapt to any abnormal stress. And then what happens? One more piece of straw and the camel falls down, because that tissue can't handle that continued stress anymore. But so say, for example, if it's the patellar tendon, what's the cause of that, though? Does the person have an ankle issue? Does they have a hip issue? Do they have, something going on with their pelvic mechanics that's causing their load to be transmitted differently? Or even their running kinematics. Maybe they're not running properly. If they're reaching farther with one foot and having more deceleration during the running phase, that could be causing more stress on that side. So sometimes it's a technical thing they're doing, right? And so you need to be aware of, what are all the factors responsible for optimizing biomechanics and optimizing performance? Sometimes it's as simple as a nutritional deficiency, right? Say magnesium, a deficiency in magnesium, so that's creating more tension in the system. The body has to adapt to the increased tension, and forces get transmitted differently through the system, right?
Yeah, I was going to say, so how important, in your assessment, is it, I know the answer to this, but I'm teeing you up here, to determine then what soft tissue intervention you're going to do? You have these fancy tools, which we're going to get to. Yeah. Do we do needling? Do we use active release? What is your way to sort your way through to know which tool you're gonna use?
So basically from trial and error and through my experience through treating, my approach is always starting with some type of needling technique, as long as they're cool with the patient. Why? Because a lot of times there's abnormal tension that's nervous system mediated, right? So, for example, if you have a mobility issue with your shoulder, internal rotation, abduction, I can put some needles in your shoulder, take them out, and completely improve your mobility without me having to do any soft tissue treatment, right? So that already takes out the neurological component, right? Then, and even some of the blood flow restriction areas, because needling basically is about increasing blood flow to the area. Then you reassess the situation, and then you start with your soft tissue treatment. And then within soft tissue, you have tools, right? So you have manual, I use my hands. I can use a tool like my fascial abrasion technique tools. You can use gua sha, I don't care what tool you use. At that you have, you can use cupping. You can, there's all kinds of different things out there that you can add, and you have to decide based on, your experience and like we talked about, maybe I'm going to do some cupping on a shoulder, and, oh yeah, that helps. And then the next time I go in and I do some manual work, it's like, oh, that helps even more. So maybe I should have just did manual work, right? And it doesn't matter, in my opinion, it doesn't matter, what you do in terms of soft tissue. If you're trained with A.R.T, or you're doing my myomatrix release, or you're doing, any other, any other myofascial release technique, fascial manipulation, any kind of those techniques, they're all good and they're all powerful. But if you know a little bit of all of them, and you can figure out how do I combine them to maximize my outcomes, it's even better. Right? And so my approach is the needling first, then I do some soft tissue, and I usually I'll start with manually, depending on what's going on. My fat tools will help release a lot of tissue tension if there's more broader area that needs to be loosened, and then I'll go in with my hands and fine tune it, and then you can assess what's going on from there. If there's joint manipulation necessary, that's usually the last thing I'll do, because very often joint dysfunction gets restored when the soft tissue function is restored, right? And so it minimizes a lot lot of need for joint manipulation or spinal manipulation if you get the soft tissue component corrected.
We asked Antonio Stecco the importance of being able to distinguish like a trigger point originally described by Travell and Simmons versus what he calls densification in fascial tissue. Do you think that distinction is important? He kind of left us with the thought of it probably doesn't matter, just treat the densification and the patient could respond.
I think, well, to me, there's a difference, right? So tissue densification, that they talk about, at least my understanding of it, is more in the superficial fascia layer. From the deep fascia to the superficial fascia, things get tight, and that's where there's some, more superficial densification. But, fascial manipulation, if you look at Luigi's work that he's been doing, it's almost like he looked at the acupuncture meridians and followed them and said, okay, because a lot of the fascial manipulation points are actually where acupuncture points are, and they coincide with trigger points, right?
Absolutely. What do you think about like the meridian? Because I wanted to ask you, because we've used the term already so far, acupuncture and needling. Mm-hmm. I feel like some, people that are trained in traditional Chinese acupuncture, they almost get offended by the people in the dry needling. And then what do you think about those two camps?
So I think a lot has to do, this is my perspective on it, because I'm a licensed acupuncturist. And so I know that the TCM people, they have to take 2,000 hours of training in order to do acupuncture. And acupuncture, traditional Chinese medical acupuncture is a global approach, right? And so you need to have a lot of information about the person as a whole, and they're basically gonna, what's your, like, do you like hot, do you like cold, do you like, dark clothes, light clothes, they're going to get your biopsychotype down, and they're going to use that information along with your symptom pattern to design a treatment approach using acupuncture points along the meridians that they feel will balance things out as a whole. So you might come in with low back pain and some others, maybe some GI upset or something, and they may not put any needles in your low back at all, depending on your whole constitution, right? And so it's a different approach. I think for MSK purposes, dry needling is a bit more effective. So what is the difference between the two? Acupuncture traditionally is selecting points along the acupuncture meridian to treat whatever dysfunction the person comes in with and their whole constitution to balance, their whole system. Whereas dry needling is more anatomical based, and so if you come in with, knee dysfunction and I find some tightness along your vastus medialis, I can go in with some dry needles, put some needles in, take them out. I can put some needles in, leave them in. It doesn't matter, how long I leave them in, for a local effect, and then I'm going to see some drastic changes in function and tissue tension and blood flow to the tissue in the area. And so, it's just a different, you're using the exact same implement, it's just your intention's different. Now, healthcare professionals like chiropractors and physios and massage therapists and whoever's licensed to do acupuncture, I've gone through my training to assess and diagnose people. Okay, my daughter, when she was a gymnast, a provincial level gymnast, and I wasn't always around to help her when she's, training and she enters, I taught her how to needle herself. And so if she could put, like, if a 9-year-old can stick needles in, sticking in needles isn't rocket science, okay? It's not difficult to put a needle in. The problem is, are you putting the needle in the right target? Right? Are you hitting the appropriate structure? And that's the thing. Are you hitting the actual acupuncture point if that's your intention? Are you hitting the actual trigger point if that's your intention? Are you hitting the anatomical structure that is necessary to be hit with that needle? Right? And so dry needling and acupuncture overlay, and even within acupuncture themselves, there's 361 acupuncture points. Then they got 48 extra points. So it's like, okay, we need to do more than just the meridian, so now let's do Watu Jachi, so all paraspinal needling. Then they have extra points between the hand. Like, they have all kinds of extra points. And not only that, they have what are called ashi points. And ashi points is, where does it hurt? Hurts here? Okay, I'll put a needle in it. And that's dry needling, right? So you can't say that, the traditional approach and, TCM practitioners are just doing pure acupuncture. Right. According to the textbook of, whatever the original, textbook on acupuncture was, the Dynasty, one of the Ming Dynasty book or whatever it's called. So, they get upset with chiropractors and physios and manual therapists that are taking a weekend course and doing dry needling, and they're saying, we took 2,000 hours to do what, you shouldn't be able to do that. And my opinion is that, listen, I'm a trained healthcare professional. I'm very good at diagnosing musculoskeletal problems, and I know my anatomy, and so I should be able to stick a needle in wherever I want, to help improve my outcomes, right? I understand what the needles do. I'm not trying to be a TCM. I'm not here to balance your chi. I'm not here to treat your, things that are outside our scope of practice. I'm not trying to treat infertility. I'm here to treat MSK conditions. And so, that the course that I developed in functional graded acupuncture or functional graded needling is an integration of different dry needling techniques, combining different approaches to help maximize your outcomes for MSK conditions, whether it's an acute injury or a chronic injury, right? There's different strategies for different problems, right?
And what's your opinion? I think so many people, we think of dry needling, we're putting needles in muscles that have too much hypertonicity, trigger points, tone, tension, etc. And then, we can also put needles in muscles that are neurologically inhibited or whatever you want to call it. Can you talk about the different utilizations? Sometimes we're needling for muscles that are overactive. Sometimes we're needling for inhibited muscles.
So like I said before, why I start with needlings is because sometimes a muscle will be in an increased state of tension because it's being neurogenic mediated. It's like a protective pattern, or for whatever reason, some irritation in the nervous system, and saying, okay, I'm just going to stay a little bit tighter. And that's going to affect mobility, right? The same thing if I have a trigger point. So what is a trigger point? A trigger point is a bunch of sarcomeres within a myofibril that are contracted. And so as oxygen levels decrease in the area, these start to contract, and now you need energy to make the muscle contract and relax. And so what happens over time, the relaxation phase gets prolonged. It gets to the state after a while where they stay contracted. Now, it's not just a trigger point is an area within a whole length of, because it creates a band. You're not just going to get some sarcomeres that contract and the rest of the sarcomeres in the myofibril are going to stay loose. The whole band gets contracted. And so very often you see a central trigger point within the myofibrils, and you see attachment trigger points all along the same band, right? And so now you look at Travell's work and you say, okay, let me see the quadricep muscle, vastus lateralis, where's the trigger points? There's 25 X's on the page, right? And so now the new books don't even have X's. They just say, here's the muscle. And why? Because there's so much variation, not just amongst where the actual acupunctures are for that, but what's your palpation skill like versus mine? Are you going to find 10 and I'm going to find 6? Or are you going to find 20 and I find 3? Right? So listen, if we sat down here, the three of us, and said, okay, we're going to shut the lights, I'm going to give you some Braille. Okay? You got an hour to start reading a paragraph. Some of us might not be able to get past ABC, right? You might be able to start reading words, right? It comes down to your sense of touch, right? And so if you can feel a trigger band and you can identify the most sensitive spot along that band that a trigger point is starting to form, you hit it with an acupuncture needle, which is dry needling technique, right? And you hit that, it's going to cause the release of calcitonin gene-related peptide, nitrogen oxide are the main things that happen when you stick in a dry needle locally. And that's going to cause a vasodilation response. What did I say? Why is the sarcomeres contracting? Not enough oxygen. What's bringing oxygen to the blood tissue? Blood flow, right? So if I increase blood flow and I create more oxygen, then it's going to relax, and now I have energy for the muscles to relax now, right? And so needling is just about bringing oxygen to the tissue, right? No different than what we're doing when we're creating microtrauma, when we're loosening up structures. You're creating microtrauma. Shockwave therapy is a phenomenal tool for soft tissue dysfunction. I mean, I use it dynamically because if you think about the principle, high-powered sound waves are penetrating into an area of density, right? And the energy is absorbed by more dense structure. You ever play with a shockwave?
We just got one in the last month.
So you get a shockwave, you put it on your quad, in the middle of your quad, and you don't feel anything. Go to your kneecap, and you're going to feel a lot. Why? Because your kneecap is absorbing so much energy, right? The energy gets dissipated by the time it gets to your femur. But if you think of the connective tissue matrix, and if I'm treating a patellar tendonitis problem, and I have a lot of tension in my quad that's causing the patellar tendon to be under so much stress, the classic approach is stick the shock wave on there, for 2,000 shots at 10 hertz and 2 bar or whatever, 3 bar, whatever you want to do, and you just kind of move it up, treat that local area. But there's all kinds of tension in the quad, and so if I put my leg in extension, there's going to be a different amount of tension on the connective tissue than when I flex the knee, right? So I do it dynamically when I treat it. So it's almost like using another extension. It's an extension of my hands, right? And the thing that I like about Shockwave is I don't have to put a lot of pressure on someone's quad if I'm trying to get to something close to the femur. I have to use a lot of pressure to loosen up tissue. I have to use a lot of pressure on someone to get something that's close. You feel a really tight band or something that's causing some dysfunction. I can send sound waves through the tissue, and the healthy tissue will let the sound wave pass more, and the more dense tissue will grab it, and you cause micro trauma and create more blood flow. It's all about oxygen. It's all about blood flow. Everything we do is about getting more blood flow to the area, and so that's why I use needles for that. Now, the same concept. So now somebody comes in and they have a quad problem. One person comes in, I find a trigger band, I find trigger points, put them in, release the trigger points, no problem. Now somebody comes in with a chronic problem. That trigger band is no longer a trigger band. Now there's fascial changes that have occurred in the matrix, not the muscle now. And we're talking two different things, right? Same concept though, right? So what happens to tissue that has been, under a state of tension for a long period of time with low oxygen levels, right? You start to get scar tissue laying down. Instead of normal collagen fibers in the matrix, now you have a less elastic type of collagen fiber, which is a result of poor blood flow. Right? And so now forget about the sarcomere. I'm talking about the connective tissue matrix. So now I can stick needles in the matrix and increase blood flow to that area so that when the tissue remodels, it's going to remodel with a more favorable amount of oxygen, and you're going to have less connective tissue that's in a less elastic forming. So you can use dry needling for trigger points. You can use dry needling for fascia. There's studies coming out now where they published a study a couple years ago comparing lateral epicondylitis with a cortisone injection and dry needling. So they put 15 needles in the lateral elbow, right? And why so many? Because I want to create as much blood flow to that area as possible, right? So it's not about sticking one needle in, it's how many do I need to influence the tissue. And so in my course, I have treatment strategies that I've been using. A lot of it's just from clinical experience that I developed over the years. So I have a pain management course and another course called that's sports injury management. And it's not really sports injuries because anybody can have that problem. It's really, what about the more difficult cases to manage? Like, some tennis elbow problems are very difficult to manage.
Sure.
Some lateral epicondylar, plantar fascia problems are difficult. Some groin problems are difficult to manage. And so there's treatments, methods that I show to kind of help increase, more aggressive needling techniques to get more blood flow to the area, right? And you just put needles in, not just one. Maybe I have to put 10 in the area, right? And so that study comparing, dry needling versus cortisone, the dry needling, was just as effective, if not more, right? And then they did the same thing with Achilles tendinosis. Dry needling, versus other injection therapies, and dry needling was, very effective, if not more, right? So,
is there a case that you have found that wouldn't have responded to all the different soft tissue techniques that and that only Shockwave was able to bring that case around? Or is it just a quicker response?
Yeah, so that's a good question, because you asked me the question, how do I know what to use and when to use? Like what's kind of...
It's a continuum.
It's a continuum. So if I use my fat tool, I use my hand, and I'm feeling like, shit, I'm not getting... Pardon my language, but I'm not getting...
You can curse, it's okay.
Oh, okay, yeah.
That's
I drop F-bombs all the time.
That's fine.
So, so as you go, right, so start with my fat tool, what kind of change I make? Oh, that's good, okay. Do I need to do more or not? More, okay, so I'll fine-tune it with my hands. Do I need to do more or not? No, that's great. Come back the next day, they're still having problems. Maybe I'll add Shockwave because after a couple sessions, I feel like I should be farther along. Or after I use my hands, it's like, holy shit, this is really dense. This is not releasing as much as I want. For example, adhesive capsulitis. Or it could be just shoulder impingement syndrome. True adhesive capsulitis is an obvious one. But a lot of shoulder dysfunction is from abnormal tension in the capsule. It's not true adhesive capsulitis. But what's causing, for example, what's causing supraspinatus tendinosis, or tears in that bicipital tendinosis, what's causing the impingement syndrome? So the humeral head is riding up, and you're grinding the humerus against the acromion, and that's causing the irritation of the tissue. But why do you lose joint centration? That's more important, right? The capsule is very often a big part of that, and maybe just a small piece of the capsule. And so in a case like that, I'm going to do some dry needling into the capsule to get more blood flow to the area, and I may also add some Shockwave if after I've done my needling, I've done my fat tool, and I've done some Biomatrix, and I still see, you know what, this is still not, the glenohumeral joint is not still dropping, it's coming up, and I'm still getting compressive forces. So then I'm going to go in with the shock wave and see if I can, get a better outcome.
So it seems like you're kind of more like least invasive first, maybe.
Yes.
Not necessarily, like as little as possible.
It's like any, some patient comes in, I had a patient come in with a TMJ problem today, and she said, yeah, I want to, they want to do surgery on my jaw. And I said, well, wait, that's okay if that's what you need. I mean, it was the first time I seen her, so I didn't know, and she could hardly open her mouth, and so I'd use my same approach. So I said, okay, let's assess what's going on, find the dysfunction. She had pain on her left side, but her right side was immobile. Her left side actually moved more. So I did some dry needling or acupuncture, whatever you want to call it, functional grade acupuncture, because a bunch of different things that I was targeting, and I did some manual treatment. Her range of motion was great. Now, my question to her is, I don't know how long the treatment's going to last, and maybe she's going to go home and have dinner and then clench all night and come back in the morning. She can't open her mouth. I don't know if she needs surgery because I didn't see her x-rays, but I said to her, listen, there are other options for TMJ dysfunction than just that. There's alpha appliances and these things that they're doing inside the mouth that can reshape your maxilla and push things out and reshape it, and maybe you don't need that. So let's try something that's least invasive first. Do you need surgery, or can you need a knee replacement, or should you try some Synvisc or something before knee replacement? Right?
Yeah. So Brett talks about all the time. We talk about trial of care is more important than anything.
Yeah.
So it sounds kind of like you're echoing that.
I think you don't ever. I mean, listen. Once you cut, you can't uncut, right? And that's what I tell all my patients. I say, listen, if we can't help you, or you feel surgery is the way to go, I'm just letting you know. Once they go in there and cut something, they can't uncut it.
It's like a haircut.
Yeah, exactly. Well, at least your hair grows back, right? So the thing about shoulders, and people have these partial tears, or they have full thickness tear of part of the supraspinatus, and we need to have surgery for that. It's like if you can restore. First of all, why did that happen, right? If you can restore function and get them doing some exercise to strengthen it and stabilize their shoulder, and they don't have any pain, why do you need to go and have surgery? Shoulder surgery is one of the most difficult things to recover from. I mean, if you're not careful about your post-surgical recovery and doing the proper treatment and therapy, you're going to end up with all kinds of dysfunction, right? Scar tissue developing, all kinds of dysfunction.
Do you have any fears, Mark? Let's just say that, you're kneeling. You use the term protective pattern, which we use that term also. So do you have to worry about taking a protective pattern away from a joint? Okay.
So this is a good thing to, this is where it comes to, I'm just practicing, and you have to be patient until I figure it out. Because like I said, I've been doing this for 30 years, and I'll have a patient come in. I think, okay, yeah, I've seen this before. I know what I'm doing. I can feel what I got to do. I treat it, like, all of a sudden, I made it worse. They'll call me and say, hey, like, you know what? I felt good walking out, but now I'm like worse than I was when I came in. Because I removed the protective pattern. Right. There's no way to know if there's no way to know if by removing the protective pattern is going to be the best thing for them, unless you fix the cause of the protective pattern after that. Sure. So you know what I'm saying? So yeah, I'm always looking to take the protective pattern away as long as I feel I can correct the cause of the irritation, so that when I'm done, they're not going to end up in a protective pattern even worse.
I would say now, when you're working with Bailey, I mean, are you nervous that you got your big race tonight? Like, are you taking into account like the timing of your needling in consideration of that? So
those are all good questions, and I can tell you from trial and error that never treat an athlete for the first time before they're running for a race, okay? And, people will come to me at different competitions, hey, can you treat me? And then, they're getting ready, can I just get ready for my race? And I've never treated them before. Last thing I want to do is do that, because sometimes their nervous system can't handle the changes that I made, or their new range of motion, their nervous system can't adapt quick enough for it, right? And so, to me, great athletes, like, the LeBron James of basketball, those are guys that their nervous system has the ability to adapt to soft tissue stresses, so at the end of the season, they're still making those 3-point shots that count, right? Where the less guys that, at the beginning of the season might be on a similar level, but near the end, their body, their nervous system isn't as fine-tuned as his, and they can't adapt to the stresses and still coordinate the motion necessary to make that basket. And so to me, that's a definition of a great athlete. A great athlete has nervous system adaptability, right, to abnormal stress, and still can perform at a high level. Right? So sometimes you go in and you do a treatment, their nervous systems can't handle the changes you made, and they're going to feel flat. And I can tell you it's happened to me a number of times, right? I treat a guy, I think I'm doing everything right, and they scap. I felt good, and they might have raced good, but I kind of felt flat. right? Same thing with any sport, hockey players, baseball players, any sport, that can happen.
It's kind of like learning to dance with somebody. And I always tell the patient that. It's like, the first time you dance with somebody, then, you're kind of learning about them.
Exactly.
And, that way.
And that's why I always recommend try something new at practice, right? Treat them and let them practice and then give you feedback on how they felt. Don't do it at the competition isn't the best place to start treating somebody. Right? Unless you have a history with them, like you said, their body, what they're going to respond like, right? Some people, so a lot of times what we do with athletes is there's some annealing techniques where you actually help calm down the nervous system and you can change acupuncture has a very neurohumoral response. And so when people are under stress, with certain acupuncture points, you can actually calm their nervous system down. And so between semifinals and finals, it's really good to throw some needles in, go chill for 10-15 minutes, because not only they recover, but the nervous system can recover better. Some people, they're great 5 minutes, their nervous system's calm down. Some people need 20 minutes for it to have the same effect. So, I could put one needle in someone and have a good effect. Another person for the similar complaint, similar problem, similar, range of motion issues, I might need to put 5 to 7 needles in. Right?
What's the difference? Obviously, you're really gifted in your ability to feel with your hands and the tool. Which one? What's the difference? Is we always quote, Dr. Levitt, who used to say the most powerful tool that's ever been invented from a diagnostic standpoint is a human hand.
Yeah.
So, is a tool just extension of your hand?
Yes.
What's it? Yeah.
So this is what I teach. Listen, you name a modality. Okay, name any modality that we use for soft tissue, other than a tool in my hands, like laser, shockwave, like all of these things that penetrate the surface of the skin. You have no fucking idea where they're going. Okay, but now I have the first time ever I have an implement where I can physically touch something under the skin. A needle is an extension of your finger. And when I teach people, and that's why it's so important that you feel a target, you identify it, now you have to feel it with the needle. That's your finger going through the skin. You want to feel that you hit that target, so you should feel it different. When you're acupuncturing something, if I feel I'm on my quad and I'm rolling over a band and I don't know how deep that is. I know there's something there. And so I can use the needle to go through, okay, I went 1 centimeter, I don't feel any resistance yet. Oh, now I feel something, and I keep going until I go through the other side. If it's in the middle, I'll go right through it. If it's connected to the femur, the next thing I hit is the femur, right? And most tissue anchors at the femur, that's where the problems are, right? At the periosteal attachments.
What about electro-acupuncture? What's your utilization? When do you decide to use that?
So my progression in acupuncture, I'll kind of give you a history of my acupuncture training. Went to Sri Lanka, came back, doing TCM stuff, mostly acupuncture for soft tissue. I took a few, neuroanatomical, like an acupuncture, like weekend things here and there, just, for interest. And then when I was at that first meet, when I met Donna Bailey the first weekend, the medical doctor there was teaching a course for physicians only. And so we had this big conversation about acupuncture, and he was teaching this really cool, Joseph Helms is the medical doctor's name, who wrote this book called Acupuncture Energetics. And this blew my mind. This medical doctor wrote this textbook, and he created a Western approach for Eastern acupuncture and using the acupuncture model, right? So surface treatment, deeper layer treatments, using acupuncture inputs to kind of, different acupuncture inputs to influence different areas of the body. It was like phenomenal. I read the whole textbook front to back, and so I convinced this guy. I said, listen, we need to teach this to chiropractors. I was like, that can't be just a physician-only thing. This is like so good for what we're doing. And so we launched the McMaster Acupuncture Program. So I was involved in doing that, and we used a lot of electro-acupuncture, and I thought, okay, this is part of the whole thing. And, when you're using electricity in needles, wherever the needle is in the body, your electric current's going to go through it, which is a good thing, but also could be a bad thing if it's close to a nerve. And then, you hook. It takes time to hook up the electricity, and then patients can get uncomfortable. You walk out of the room, and then, it can be uncomfortable. But the approach was using needles, using electricity all the time. And then I started training with Yun Tao Ma, who wrote this book called Biomechanical Acupuncture.
That's what I was trained by.
Yeah. So I met with him, took his courses, and then actually I was going to teach for him. So I started teaching for him. And then, he was going to do a bunch of research. I was going to take over teaching his courses for him. And then something happened. And so he had to say, look, that didn't work out, or it's not going to happen. And so, they need to take their courses back. But he said, okay, you do what you want with your material. And no electricity. And so I started playing around, okay, I'm going to stop using electricity for the next month and see what the difference in my outcomes were. And almost 95% of the time, there wasn't any difference because I was also adding other modalities, right? If I just did needles and nothing else, maybe the electricity has a bigger impact. But when you're combining it with, the fat tool and manual techniques and other things, then it's not so significant. So now I very seldom will use electricity. Way more comfortable for the patient. The techniques that I'm using are more dry needling and less acupuncture based, way more effective, and patients are way more comfortable.
Not holding up a room. Some it can create a little bit of a bog in your, the people are sitting in there for 10 minutes.
I mean, even the acupuncture treatment that I do, I usually leave people in a room for 15 minutes to 20 minutes with the needles in, even dry needling, right? I don't do the in-out class. So the classic dry needling is hit the trigger point, mess around with the needle, and take it out, look for that twitch response. And they published a paper in 2016, you don't even need to do that, right? Just in effect, if you put the needle in, take it out. So there's no difference, right? You don't have to have a twitch response. And so, the electricity, to me, there's very so to me, so really what is electricity doing, right? And, there are studies coming out where they're using current to help with healing in mice. They're doing some studies with electrical acupuncture to promote healing in mice. I can't remember the exact frequency. It might even be microcurrent they're using. But, you can use it at that approach. But technically, the currents that you use are, a low, so acute pain, someone comes in, high frequency, anywhere from 80 to 120 hertz, and you're going to get an enkephalin release at the spinal cord level, the segmental level where the current's coming from, and it's really quick, immediate release. Mm-hmm. So if I put in electricity needles around the knee, high frequency around the knee, at the segmental level for this knee, I'm going to have, some pain relief pretty quickly. Okay, high frequency. Low frequency, a lot of people do this as a form of analgesia, 20, 30 minutes of electricity, 2 to 4 hertz, you're going to get an endorphin release in the central nervous system, which is going to have a global effect on your body. So it's not, it's not just where you have the needles. The whole body will, because it's a central nervous system response. And you get an endorphin release, and you get a more global. It takes longer to kick in, and usually, when you accumulate treatments, so 6 to 8 treatments, you'll hit a peak in the central nervous system process of releasing it. And so how important is that? If you're doing all these other modalities, you don't necessarily need to have that analgesic effect because I'm going to fix the soft tissue, problem before that.
What's your reasoning for leaving the needles in for 15 minutes in?
Because so now you're getting into my integrated approach. So if you leave the needles a bit longer, you're going to have a more central nervous system effect, right? So if I put the needles in and take them out, I'm going to have a strong local effect. If I want to also affect the central nervous system, so anytime somebody has chronic pain, even acute stress, their central nervous system is going to go through a cascade that affects all kinds of things in their brain, and so leaving the needles in will help calm that sympathetic drive down, and it's really helpful for stress, for a lot of other things. So it's more of a central nervous system treatment for leaving them in. So now I'm getting a local effect, leave them in longer for a central nervous system effect.
Yeah, I love it.
Is there any specific diagnosis when that walks in, or a specific thing that you feel like, okay, I'm definitely using it electro today?
Yes. Well, it's never the first treatment. Uh-huh. So I never use electricity on the first treatment because usually, unless they're experienced getting acupuncture, because just getting acupuncture freaks people out. Now a lot of electricity. If somebody comes in and asks for it, sure, I'll put it in because some people are, I like it when I have electricity. Okay, then I'll do it for you. But usually, so for example, adhesive capsulitis. If I'm doing my technique and I feel like it's not working, sometimes the contraction of the pulsation will help loosen connective tissue a little bit. So sometimes
when you use a low frequency.
I'll use the low frequency as long as I feel like I'm getting a contraction. So the muscles contracting will help release some connective tissue. So it has that mechanical effect, more. And then if I've been treating somebody and there's still a lot of pain after 2 or 3 treatments, and I want to try to help stimulate the central nervous system effect stronger and have a stronger analgesic effect, then I'll add the electricity. But I can't count how many times I used electricity on one hand this whole year.
Okay.
Like in Ma's approach, there was always a matching up to, whatever we might be needling in the periphery, like what they call the PA points in the spine, and like trying to coordinate those.
Okay, so so this is the integration model here, because you're talking about Chen Gun's intramuscular stimulation stuff and incorporating some of that with, trigger point needling and then his homeostatic points, and so you have to be careful about what we're talking about. So segmental points are extremely helpful as well. So again, there's a difference between an acute injury, somebody who's had some soreness for 1 or 2 weeks, and then more chronic cases, right? And so at the segmental level, the dermatome, myotome, sclerotome at the segmental level, it's very good to needle those, especially in chronic cases, because you're going to get hypersensitization coming from the segmental levels. And so, if you know anything about Chan Gunn's work, the IMS stuff, they just go to the segmental level, palpate for hypersensitivity, needle these bands that are tight, desensitize the area, and that decreases the hypersensitivity and the central sensitization that's occurring. And so it's very, very good approach for more chronic cases and more stress-related things. It can be very helpful. And so my approach is very similar. So you do local, you do regional, you do segmental, and you do central nervous system points. Right.
Yeah, perfect. Thank you. And we asked Mike this about, the whole mechanism of why soft tissue treatment is working has now kind of become questioned. And off the record, it was so funny because Mike was basically like, I got 30 professional athletes I'm going to see. Something I'm doing is working. It's kind of what he said.
Yeah.
So, but I mean, when you're in the evidence-based circles and we're starting to talk about like what is the mechanism for how this is starting to work, even if you don't know the exact answer to it right now, what do you feel is working?
Okay.
Yeah.
So this is why I feel like the myomatrix, it's not about muscle tissue and muscle. It's about restrictions in mobility, right? And the nervous system's ability to adapt to those restrictions. And so if you're good with your hands and you can identify structures that are restricting mobility and you have a method of releasing it, like I was showing you before, sometimes you have to shorten, it's not about lengthening muscle, it's about identifying the movements that will maximize the tension, and you release that tension in whatever range that's required, right? And so sometimes shortening a muscle will actually pull on connective tissue because you're going, there's a resting length, shortening length, and longer than the resting length. And so in both directions can create tension. And so you need to identify that and release it in order to, like I was explaining, if I'm checking somebody's range of motion, I'm flexing their hip, and at 45 degrees I'm starting to get tension and I have to push harder and harder to get to 90, I'd be able to, with my hands now, feel where that's restrictions coming from. Right? If I do a straight leg raise, now I don't know if it's calf muscles or if it's hamstring. If I bend their knee, now it's going to be something around the hip, right? Is it coming from higher than the glute, or is it coming from the hamstring? And then you have hamstring and adductors, and like I said to you, I could have a quad problem that's causing my hamstring to be restricted. So I could have abnormal tension in my quad, and when I do a straight leg raise, it's going to affect my hamstring length. And so I need to release the quad to fix the hamstring. You understand?
Oh.
I don't even have to touch the hamstring, and I don't even have to touch the hamstring to improve its length. And this is where you need to understand the global system is a global approach. And I was telling you about that. I don't know if we were on air when we were talking about that, but when you do functional testing, so if a guy's laying on his back and he does a straight leg raise, one leg goes to 90, one leg goes to 45. If you do any functional test, there's going to be a problem, right? But what's causing his leg not to go past 45, right? And so you have a lot of options to choose from. And so in some cases, the SI joint could be restricted, right? And so you can release the SI joint ligaments with one needle, and the guy goes 90 to 90, right? I didn't touch anything other than in that, right? You could potentially treat his hip flexor, which makes sense too, right? Maybe he's not able to activate his, muscles that are flexing his hip. That could be also an approach, right? You don't know until you try, right? Try one thing, reassess. Try another thing, reassess.
I think for young clinicians too, I mean, they get so caught in the trap of like the orthopedic geographic pain game where your shoulder hurts and we got to do everything to the shoulder. So what do you say, like when you're teaching your students and or the doctors or your therapists you're teaching, how does your system expose and give them the confidence to treat away from the site of pain?
I always tell them, this is the number one. My approach is this. What do you need to know about the injury? Where does it hurt? Show me where it hurts, right? I need to see and you need to touch so I know what anatomical structure is a pain generator. So the advice that, okay, so I'll continue. So what's the pain generator? Okay, and so that's going to be your diagnosis. Basically, you're going to tell them what muscle is hurting them. They're going to point to it. And you're going to give them a muscle name, which is a bullshit diagnosis, right? And so then you're going to, assess the region and say, okay, what's restricted? What motion is restricted? What's not moving properly? What's causing that not to move properly in the local area? Then you're going to start checking regionally, right? And say, okay, I'm working on the shoulder, but now when I get to the elbow, this guy can't even supinate his arm without like rotating his whole humerus because there's so much tension in the forearm. How do I know that this isn't causing this problem? Right? And you don't know until you assess the situation and figure it out, right? And if you release some tension in the forearm, all of a sudden his shoulder starts to improve mobility, right? Like Stecco's work is really, some of the stuff that they talk about is really profound on how, so they've got, the points that move the body in whatever, fascial, or what do they call them? Fascial tones. No, they're called fascial tones. Right? So you have a fascial tone for flexion, you have a fascial tone for extension, for medial motion, lateral motion, one for internal rotation, one for external rotation. And so, which is, the concept is balance the cylinder. Okay, so if my leg is a cylinder, right, if everything is balanced front to back, side to side, inside in rotation, medially and laterally, I'm going to have an optimal functioning leg. And that's exactly what you have to do. If I fix flexion, extension, medial motion, lateral motion, but I don't work on rotation, I'm not going to have proper movement. Because why? Nobody moves in a complete straight line. There's going to be some component of rotation in there. And so that's the big component of the myomatrix, is you're always going to look for a medial or internal or external rotation component whenever you're treating. So if I'm treating your forearm, I'm not just going to extend your wrist, extend your elbow. I'm going to want to also know, does supination and pronation have a big impact on the tension wherever I am, right?
That's perfect.
Beautiful.
Yeah.
What do you think as far as, the Yonda's original theory on postural and phasic muscles?
Yeah.
Does that even matter to you?
Yeah,
or no?
I listen, his upper cross and lower cross syndrome patterns to me are great, if, especially when you're learning, because those typically tighten.
It's a framework,
right?
yeah.
And so this is what I tell my students all the time too, well, we were talking about something about students and tell them, and I kind of was going to say something about what I tell them.
Giving them confidence for treating globally.
Yeah, so, okay, so the Yonda thing, because I forgot what I was going to say. I went on to that thing, but I had something I wanted to mention. So the Yonda thing, I think, is important because those muscles tend to tighten, right? And, those come inhibited. So one of the things that, Yonda stuff where you can talk about, you have all these people saying, oh, my glute's not firing. Come in with back pain. Oh, yeah, because your glute's not firing. Why the fuck is your glute not firing? Like, does it not notify? Is a nerve cut so it doesn't notify? Like, your nervous system is wired to perform at its peak ability. Okay? The only time your glute's not going to fire is if your hip can't extend. Because then your body's going to say, why the fuck do I need to fire if I can't extend my hip? Right? So, what do? Fix hip extension, the glute will fire, right? And that's kind of Yonda's approach. There's certain muscles that tight and they cause inhibition. Why? If I'm super tight in my pec minor and my shoulders are protracted, why the fuck would I want my rhomboids to fire? My brain's going to say they don't need to fire because I'm not going to try to fight all day against, these muscles that are pulling your shoulder blades forward, right? You release this, now they're going to say, hey, I might as well turn on because there's something for me to do.
Path-based resistance.
Yeah, exactly. And so a lot of his upper cross and lower cross syndrome patterns are brilliant, but it's not the only thing that can be a problem. It's a great place to start, especially if you look at somebody and they have upper cross pattern, or you look at them and they have a lower cross pattern. But concepts are, to me, what's really important about that. And that's exactly what I'm telling you. I have so many people coming in and saying, yeah, I'm running, 10K, my back starts hurting, and they get an assessment, yeah, your right glute's not firing. No kidding, because my right hip's not extending. Right? And so what's the problem? Not my glute not firing. If my hip can't extend, I'm going to go to trunk extension, and I'm going to start having back pain over time, right? So if I just fix the muscles that are tight, improve motion, then my glute's going to start to fire. Okay, does it need a kick in the ass? Sometimes, yeah, you need to do some exercises. Like I told you, the final part of functional integrated therapy is the functional integrated training.
It's kind of the debate rages on as far as like the level of neurology we're affecting with manual therapies or exercise. So you have, of course, spinal cord reflexes. We have subcortical areas of our brain that are getting affected. And you, of course, have cortical areas. What what levels of neurology do you think that are being affected with needling?
Oh, I mean, that's okay. So this is what I look at in the functional integrated therapy model. What do you want to, what creates optimal function in terms of biomechanics? You want optimal functioning nervous system, you want optimal functioning soft tissue, you want optimal functioning joint mechanics, and you want optimal metabolic activity, right? Those are the things that are important. And when you stick a needle in somebody, you're affecting everything through the nervous system. Okay, it's primary, obviously you're creating microtrauma locally, but they're all nervous system reflex things that are occurring, right? So you're creating from local levels, like I told you, I put a needle in, take it out, my brain knows you did it, but mostly there's a strong local effect, right? If I leave them in longer, I'm going to have a stronger central nervous system effect. And so you're going to, with a needle, you're going to create all levels. But the same thing with manual therapy, right? If I touch you, I'm going to have a local effect, but I'm also going to have a central nervous system effect. Just like if you're having a problem with your shoulder, I release tissue, all of a sudden your range of motion gets back to normal. Your motor sensory coordination for movement gets back to normal. That's your brain saying, okay, now I can improve my mobility. Now I'm not going to have an impingement problem when I lift my elbow up, right? That's what I'm saying. Musculoskeletal pain is soft tissue dysfunction. And that's why you asked me before, do you chase pain? You look at pain. Pain's not the issue. If I restore soft tissue function, the pain should go away, right?
Right, yeah, that's amazing.
And then how about, you kind of mentioned it though, where does the training piece play? Like what are some of the principles that you're utilizing for that? Those kind of things.
Okay, so in the functional integrated training, all depends on where they are when they come in, with the injury. Most important thing is you want to make sure they have proper optimal mechanics before you start doing a lot of strengthening. Sure, you can do activation exercises, early, but you want to go through a progression of patterns of movement to improve function each stage of the game, right? And so DNS stuff is really good, but combining it with other rehab stuff. So walking them through a progression of exercises, and somebody might progress from the level 1 to level 5 in 2 days, right? But you want to go step by step to make sure everything is moving properly and coordinated proper, good movement, good motion, and then you start strengthening conditioning. And basically depends on what they are. Are they a baseball pitcher? Are they a tennis player? Are they a bowler? You want it to be sport specific. You want it, there's so many variables in that. That's what's great about what we do. You have 5 people come in with a shoulder problem. You got to figure it. You got to play like Sherlock Holmes. Right. Is it an elbow that's causing it? Is it your neck that's causing it? Is your scapula causing it? Is your AC joint messed up? Is your SC joint messed up? Right, you're in 5 different treatments. That's the thing that I love about it.
And you got different levels in the techniques that you're teaching. You can use this opportunity if you want to kind of talk about like the different levels of I think you called it FIT, right? Or was it?
Oh no, so functional integrated therapy is the trademark name I use for the system that I use in my office. But like I teach functional integrated acupuncture, which is an acute component. So there's an online component that's all the TCM stuff. Then there's the hands-on component is for starts with acute and chronic pain, and then there's another module for sports injury. My dry needling, there's just 2 modules. There's a acute and chronic pain, sports injury. And it's all dry needling, no acupuncture stuff, and.
Is this kind of an amalgam of Scap's life?
Right.
So I'm assuming, because I feel like everybody kind of agrees, like dry needling is a little bit like the Wild Wild West. Like there's stuff you're like, okay, this makes a lot of sense, and then sometimes you feel like, well, they're missing this whole component over here.
Yeah. So and this is what I teach. So what I say to my students when I'm saying, look, I'm going to show you what I do, and I'm going to show you all the techniques that I incorporate when somebody comes in. If you come to my office and you watch me treat, and you see what I'm doing with needles. Everything that you're going to, by the end of this, the 2 weekends, you'll have all the skills that I use every day in my office. But for you, I don't know how you work and what you want to do. Maybe you want to do something. Take the concepts that work for you, integrate the needling techniques that you like best, and use them. Do you have to use CNS target or the PA? Do you have to use segmental? No. You're not. You're going to have good effects if you just do whatever the heck you want to do with any of the techniques you use. Because I can tell you, if you put needles in somebody's deltoid, and if I put 3 needles in the anterior deltoid, 3 needles in the middle, 3 needles posterior with someone with shoulder pain, doesn't matter what I hit. I'm going to have better results than not doing that at all. Okay. Now, if I identify specific, so I call them targets. Why? If you hit the target, you get points. You hit the bullseye, you get the most points. The closer you are to the bullseye, the better your outcomes
That's well
are
said.
going to be.
I like that.
Right?
Really
Yeah.
Yeah.
The better your outcomes are going to be. And so what does it come down to? You need to identify the target. If you don't know your anatomy, so all of the courses I teach, whether it's myomatrix, whether it's acupuncture, guess what I'm teaching? Anatomy. Why? Because if I'm doing a lab on the lateral elbow and I'm saying, okay, you need to put this needle in the attachment of the extensor carpi radialis longus, people can't find it. You know, when you look and say, okay, so we send out pre-study material. Here's all the anatomy you need to know. If I read it, they all look familiar, but now you got to find it and you got to hit it. Okay? So for example, if we're doing a lateral ankle problem and we're talking about hitting the fibularis longus, okay? So I want you to hit that muscle. Not what's tight around it. Most people put needles in the soleus because usually that's tighter unless they have a problem. And so I'm going around showing, okay, this, this is the soleus, this is the fibula, this is where I'm teaching anatomy. That's all I teach when like I told you, my 9-year-old can throw needles in somebody, in herself. Okay, she can stick needles in herself. Right. Sticking a needle into a body is not rocket science, but knowing the body in a 3-dimensional way, so that the most important thing about a needle is, what is the tip of my needle hitting? Where is it ending up, right? If I want to hit the glenohumeral joint and I'm going to go in at whatever angle I'm at, is the tip of my needle at this entry point going to hit the glenohumeral joint, or am I going to go behind it or in front of it or beside it?
What, in your opinion, are the best resources for learning anatomy? Like, what do you recommend? What are the...
Well, this is one of the things at the end of my courses always. A SCAP, you need to teach an assessment. You need to teach the assessment course. I don't know the answer. I think using those visible body and any 3D anatomy thing, and then taking a region of the body, reviewing your anatomy, then that week take all your patients and do shoulder and touch every single structure until you can do it blindfolded and you know exactly everything you're touching.
Right.
You have to transfer the 2-dimensional image on your screen and in your book to touching a 3-dimensional person. And that's the hardest thing for people to do. Because I'm telling you, for example, we target the piriformis muscle, right? And how big of a needle do you need? Well, how big is their butt, right? The bigger the glute, you have some NFL players, you have 8-inch needles that you have to use to get into the posterior hip, right? So, but still, you have a big glute, and I can hit that target from anywhere. I can come from, above, I can come from below, I can come from beside, laterally, and I come medially. But the tip of my needle has to hit the piriformis. I don't care where my entry point is. And some people, have no idea. They know their entry point because they feel something, but instead of doing this, they're putting their needle like this, and they still can't see where the tip of their needle's going in their mind,
Sure.
And I don't know how you train somebody to do that. You guys have any ideas? Because if you do, I would really like to be able
No, but I think like one of the keys, if we're teaching a manipulation course, we say the same thing. It's if you don't know functional anatomy, you can't be great at this. You can't.
What are some resources for functional anatomy? Because even that, you can't go and say, functional anatomy for runners. There's descriptions on things, right? So one of the things that I'm doing for my course as a prerequisite now is I do an online, like I do a 3D review. I use primal anatomy, or I use complete anatomy, right? I use one of those 3D things. And so when I'm teaching, so if we're going to do your shoulder, I go through all the anatomy of the shoulder with a 3D thing first, so people can hopefully visualize it 3D. And then I take the person and I go through all of the anatomy, I call it contact anatomy, identifying all the anatomical structures. I draw on the body, and then they have to draw, whatever targets we're hitting, they have to draw on the body. And I can tell you, 50% of the people, when we do the deltoid, do not know the anterior and posterior margins of the deltoid muscle. This blows my mind. Okay? People do not know how to trace the deltoid margins from posterior and anterior. 50% of the time, people get it wrong. Like 50% of the class get it wrong.
Yeah.
It's really mind-boggling, and this is like the most superficial muscle. So now, how are you going to hit the infraspinatus or supraspinatus, or how are you going to hit subscap, or how are you going to, if you can't know, this is like, I can palpate, I can see it. How can you not draw it, right? Because we're looking to do, a band in the anterior, a band in the middle, a band in the posterior, just to kind of, the shoulder is easy to start with. So that's the first thing we start to needle, right? And it's amazing. And so, now I'm going to do an online, you have to pass the online portion, and I'm going to have regional anatomy review for everything. I'm going to have the anatomy review, then I'm going to take a model and go through the palpation, and then I'm going to have questions. I'm going to say, okay, you tell me every structure that be from the skin to my bone in this point. List them, right? Here, what's this? What's under the deltoid here? What's under the deltoid here? What's under the deltoid here? They need to know all that.
Yeah.
Right. I want them to know that before they come to the course.
You mentioned earlier about a player that maybe takes a fastball off their quad or a puck off their quad. Are you using needling for those acute injuries for hematomas and stuff like that?
Yes. So there's acute methods for acute injuries. There's methods for acute injuries and methods for subacute to chronic. And for sure, day one is going to definitely help. You want to get blood flow through the area. You want to release abnormal tension in the area, and so it's really helpful to do that. Yeah.
Nice.
Beautiful. Man, we covered a lot of stuff there. That was awesome.
Yeah, you did a great job, Mark.
You crushed that. Scap.
Yeah.
So where can people find your tools? Where can people find your courses? Those types of things.
So thefitinstitute.com, I think, has. I'm not really social media, savvy, but I think that website, at least if you go to courses, it'll list the courses. So, I also teach a taping course. I could have talked to you about that too. It's called performance taping, and it's a whole different model than any taping out there. But anyways, I don't teach that many courses. I'm gonna actually turn it into an online program.
Nice.
Yeah, it'll list all the different courses I teach and where they're coming, or you can always send, hey, when are you going to be in our area, or hey, can you come down and teach our group and do that stuff. So
what about these fans? My gosh,
Yeah,
this thing looks fancy. Tell us about these.
So fattool.com is the fat-tool.com, I think, is the website, and then there's different tools. So this is like the first one that I invented, and then my hands started, like when I used the small end for doing technical stuff, this was getting heavy, and so basically I cut this off. And so there's just this piece here. So I have a mini tool that's called the mini model, and then this is like the pro model. And then I have, another model that doesn't have so many technical edges. A lot of massage therapists like that. And then this stick, you can find the stick under fascia stick. So this is more for personal use. So a lot of athletes always say, hey, can I take one of those? And I'm not going to give them one of the pros. So I designed this to have no sharp edges, but it has the same surface technology, and they can do everything, to themselves. So a lot of athletes, find it helpful for recovery as a pre-warm-up kind of thing to do. So
beautiful.
Yeah.
I love it. Thanks for giving us a little insight into to the brain of Scap and for the integration. I mean, you're legendary for that. I know that the years of experience have definitely helped you, but you still feel passionate about it, which is so awesome. And
always more to learn.
Yeah, well, I was telling his generation doesn't know who Scap is. When I was, I'd be in between your two generations, and you were a legend in active release when I was a student, and so I think the world needs to know more about what you're doing, and you have so much knowledge. I think also just like treating those high level athletes who a lot of people are intimidated to treat. I think you have a lot of insight for that.
And so the important thing about treating high level athletes, is you treat everybody like a high level athlete, right? Everybody that comes into my office is going to be treated the same as anybody else. The only difference is, when you're working with a professional athlete, they're going to have an hour of time so I can fine tune other things, right? In my office, people are coming in just a shoulder problem. But, like you work with baseball, so when I work with the Atlanta Braves, I'm treating like 13 pitchers every day. And so I don't have an hour with them. And so I treat them just like if somebody came in and said, can you fix my shoulder's messed up today? And so I treat them exactly like I would treat my patient who came in with shoulder problems.
What is your typical treatment session in this setting, like in the...
Yeah, so in my office setting, we normally book 20-minute sessions. Yeah. Doesn't mean you're going to be here only for 20 minutes, because usually if I put some needles in you, I'll leave, go to another room, come back. So usually people are here for, 30 to 40 minutes typically. So it'd be like needling and then manual therapy.
Right.
Whatever modality I want to throw in that day.
And you are working out of looks like multiple offices here in Toronto?
Yeah, so I'm a clinic director for a bunch of clinics, so a chiropractic director or director of chiropractic services, and so I train people to use my functional graded therapy model, and then I get requests from different clinics to say, hey, can we get someone that does your stuff? And so I train them and put them in different clinics, and so I have about 25 different locations. So on my Fit Institute site, there's a treatment thing, and you can see the different locations. And
you're always hiring if people are interested in potentially.
So there's always requests for clinics and we're expanding, and there's a lot of things happening where we're starting to do some really cool stuff. So I have some professional athletes that say, hey, Scap, you got someone who does what you do, and so I have some people that are traveling the world with professional athletes full time, and I'm getting more and more of that, right? And so usually somebody who's new that I train that has good skill set, and if they're interested in a specific sport, and I need somebody to work in whatever sport it is that they want to travel full time around the world. It's pretty cool. And then I get really cool gigs. I have this gig with German national freestyle ski team, so I'm going to go to Finland just to kind of do the first workshop, get all the athletes organized, and then at all the World Cup events, some of my staff they can go wherever they want. So anybody can say, okay, I'm going to go to Italy, I'm going to go to Austria. So I'll give them the list of the events, and they just sign up whoever wants to go, and they go for a week and have a blast. So
that's awesome.
Yeah.
Helsinki's a lot of fun. Is that?
Yeah, except it's not Helsinki. It's like way up in a mountain somewhere.
Oh.
I'm like a 6-hour layover when I landed in Helsinki.
Beautiful. That's what wine's for.
Yeah.
Yeah, exactly. All right, awesome. Scap, thanks for giving us some knowledge today and for sitting down with us.
Yeah,
and
great. It was fun talking. It was fun talking about all this.
Yeah, well, I'm sure we'll our paths will cross again, and we'll have some more information, and we'll put all this stuff in the show notes. And thanks again for sitting down with us.
Great.
Thanks,
Yeah, thanks, guys. Have a good day, man.
Yep. Good to see you.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.